Hospital infections with P. aeruginosa are redefining how we understand sepsis risk. Hospital-acquired infections have always posed serious threats to patient recovery, but few organisms are as cunning as Pseudomonas aeruginosa. This opportunistic bacterium doesn't just stay put. It can shift between the lungs and gut inside the same hospital patient, silently increasing the danger of severe bloodstream infections like sepsis. But here's where it gets even more concerning. New research suggests that P. aeruginosa's ability to move within the body may be far more common and more complex than previously believed, tracking the bacterium's movements inside the body. In a groundbreaking metagenomic study, scientists analyzed matched lung and gut samples from 256 hospitalized individuals to trace how P. aeruginosa spreads inside a single host. From these patients, bacterial genomes were successfully recovered in 84 cases, allowing researchers to detect 27 people in whom the same bacterial strain appeared in multiple body sites. Simulation models helped confirm that this pattern was not just from repeated hospital exposure. It was actual bacterial movement inside the body. Using ancestral reconstruction techniques, the team discovered that P. aeruginosa typically takes root first in the respiratory system, especially the lower lungs. From there, it tends to migrate toward the gut rather than moving the other way around. This finding challenges earlier assumptions and shines light on a new infection pathway, suggesting that lung infections might act as the springboard for later, hidden colonization of the digestive tract. And this is the part most people miss. Respiratory infections may not end at the lungs, but instead give rise to long-term reservoirs of infection deeper within the body. Resistance and adaptability, a deadly combination. When researchers examined how the bacteria varied within patients, they found something alarming: strong enrichment of mutations in genes linked to antimicrobial resistance. Regardless of whether the bacteria came from the lungs or gut, these genetic changes suggested that hospital environments push P. aeruginosa to evolve rapidly, producing multi-resistant strains capable of surviving in multiple organ systems. This resilience not only makes infections harder to treat, it may also help the bacteria persist unnoticed and move more freely within the patient's body. Why this matters for patient care. Rates of infection spread between body sites turned out to be significantly higher than earlier studies had shown. The research suggests that after an initial lung infection, P. aeruginosa can linger quietly in the gut for extended periods. Such colonization can act as a continuous infection reservoir, ready to cause another outbreak, or worse, trigger sepsis, especially in critically ill or immunocompromised patients. For hospitals and healthcare professionals, this study delivers an urgent message. P. aeruginosa should no longer be viewed as a static infection limited to one site. It is a dynamic, adaptable pathogen capable of internal migration. Infection control strategies must evolve to detect and interrupt this lung-to-gut transmission pathway. Better screening methods and targeted interventions could help reduce future sepsis cases and improve patient outcomes. Reference: Fisher, LWS et al. High-frequency body site translocation of nosocomial Pseudomonas aeruginosa. Nature Communications. 2025, 16:9862. This article is distributed under the Creative Commons Attribution Non-Commercial 4.0 license. What do you think? Should hospitals treat lung and gut infections as a single, connected threat rather than separate issues? Or do you believe this risks overcomplicating infection control protocols? Let's discuss in the comments.